All right, everyone, we'll go ahead and get started on chapter 30. This is over head and spine injuries. And so it's a pretty interesting chapter. You'll see that as I say all the time in trauma, there's quite a bit of overlap from the previous chapters, but that's okay. We'll cover it. We'll also talk pretty heavily on like cervical spinal mobilization and helmet removal. And of course, that'll be covered pretty heavily in class with how to properly do that. Okay. And so the nervous system doesn't need much of an introduction, but it's a complex network of nerve cells that enable all parts of the body to function. And so the nervous system is we have the central nervous system, which is the brain and spinal cord, and then the peripheral nervous system is all the peripheral nerves. And so that is the distinguishment between the two. So remember, the central nervous system is what is located centrally, as in the brain and the spinal cord. It is two components to the central nervous system. Students often forget about the spinal cord. Okay. And so, we're going to talk about and I've covered this but some terminology of head trauma, right? And so it's both head injuries and traumatic brain injuries are considered head trauma. So, this could be a baseball bat to the head, a fall where they strike their head on the ground, a punch to the head, a kick to the head, a car wreck where their head gets banged, a gunshot to the head. I mean, it could be a lot of different injuries to the head or head trauma. And then the head injury itself is, traumatic injury to the head that may result in injury to the scalp, head, or skull. Okay. And a TBI or traumatic brain injury is what it sounds like. This is injury to the brain that is caused by an external force, i.e. trauma. So from a fall or a punch or a kick, you could end up, or a car wreck, you could end up with a TBI. And so this is this is bad when the brain gets injured because an important concept to know about the brain and the spinal cord is that they never regenerate in adulthood, right? So like once you have your brain and spinal cord past puberty, especially, like, it's done. It doesn't regen. And so these people, they get brain injuries or stroke or whatever. That's it. That's all God gave you. So it doesn't heal itself. It doesn't regenerate like perhaps if you get a paper cut or a cut on your skin, it's going to regen. That doesn't happen in the brain. And so when you're stuck with these injuries, you're stuck with them for life, unfortunately. And so the nervous system's, again, divided into two sections. What's the central nervous system, CNS, composed of? The brain and spinal cord. The peripheral nervous system is the periphery of the peripheral nerves. And so, whoops, don't do that. Let's just look at this. So what happens is, let's see if they're talking about reflex here. So there's a pathway, okay? And so basically if your brain wants to send something out, right, it's going to somewhere in the brain, let's just say it's the motor cortex of the brain, right? And so it's right here, like midbrain. And so it's going to send it out. And so it goes out through the brain, through the spine, or through the brainstem, down to the spinal cord. And then so this is all central nervous system. But then right here, when it breaches off of the spinal cord, that is the peripheral nervous system. And so it is going to go into the periphery and tell whatever is supposed to happen. Okay, so it would draw like this, right? And so it would send its fire to those muscles and tell them what to do. Well, there's also a feedback that comes back through sensory and motor that would come back and tell the brain. And so this is a loop, right? And so that's kind of intuitive that all that is working together, and it's all connected. Now, we've covered these bones in the previous chapter, but it's worth reviewing. So the mandible is the word for the jaw. The maxilla is the top part where the mustache should be, right? Like right here. The zygoma, this area right here is called the zygomatic process, is the cheekbones, okay? The orbit is this little portion, is the eye. The nasal bone, remember the nose itself is not a bone, it's cartilage. And then the cranium. So if we were to talk about, like, this is the frontal bone, this is the temporal bone, parietal, occipital, and these are all joined together with these things called sutures. And so these are fusions of bones. And if you were to take someone's, like I've seen human skulls in cadaver labs, it does look like that. There's suture lines, okay? And so to the words on the screen, what the scalp is this is subcutaneous tissue that contains the major vessels under supplying the scalp. And so the scalp is where, like, basically the hair, right? Like, this is the scalp. And so the hair takes actually a decent amount of blood flow, and so it's very vascular, the scalp. And I've said this all the time. Someone's going to have like a 1 millimeter lac to their head right here, and they're just drenched in blood because it bleeds a lot. And so be aware, the scalp is very, very vascular. And the skull is the cranium and facial bones. So this whole thing is called a skull. Well, this whole thing is called a skull. And so I've seen this tested. I don't know why they love you to know what the foramen magnum is. Foramen means hole, and so and magnum means big, right? And so it means big hole at the base of the skull, and so that's where the brainstem will travel through out of the brain and the spinal cord. Not the brainstem, but the spinal cord will travel through the foramen magnum. And so the four major bones of the cranium are the occiput, temples or the temporal region. It's called the temporal region because this is one of the first areas that men and women will go gray and bald. And so temporal means time. So as time goes on, you bald. And so, or the parietal region, that's going to be up here, or the frontal region, and the occipital region is the back. So you do need to know those regions: parietal, frontal, temporal, occipital, or occiput is the prominence. The face is composed of 14 bones. You don't need to know all of them, but you need to know the ones that I showed you on the previous slides. The maxilla, the mandible, and the zygomatic process, or the zygomas. So the orb is made up of frontal bone and two facial bones. Remember, the nose is mostly cartilage. Now, you do need to know how many are in each. So there's 33 vertebrae, okay? And so how I like to remember this, don't just throw your hands in the air. It's okay, we can work through this, is you might have breakfast at 7 in the morning, and then lunch at 12, and then dinner at 5 again, and then 5 minutes later you're hungry again, and then maybe another 4 hours later you might want a bowl of ice cream and dinner, as you're going to bed. And so if you think of meals throughout the day, some students will even just add these together and say, oh, well, it's just you would have dinner at 9 or dessert at 9. And so just remember, breakfast at 7, lunch at 12, lumbar at 5, 5 and 4, or you could add them together and say it's 9. And so the cervical is the neck. It's intuitive, right? There's saying what the C7 is saying is there's 7 of these. 1, 2, 3, 4, 5, 6, 7. Okay, and so that's what they're saying. And then the thoracic spine has 12. Okay, notice there is a natural curvature of the spine. The lumbar has 5. Okay, a very common issue of herniation is right here, where we get back pain, back issues. And then the sacrum and coccyx are the last pieces. Okay, so where does the pelvis join the spinal cord? It's at the sacrum. Okay, so the pelvis, the hip bones, where you put your hands on your hips, it joins at the spinal cord or the spine at the level of the sacrum. Okay, the coccyx is like a little tail. It's very small. So do know those. Sometimes that's tested, and I don't know why, but you do need to know those. Now, if we were to take the spinal cord and slice it this way and look into it, this is what you're seeing. And so this is the anterior part. So, or this is the posterior part. So if you were to put your hand on your back, this is the side you're feeling. So this is posterior. And so you can feel these processes, these transverse and spinous processes on skinny people if you run your hand down their back. And you can break these. In fact, young athletes do break these. And so this is, you can feel this. And at the interior portion, meaning like up front, the interior, the face side, there's a thick bone called the body of the vertebra. And so this is a pretty thick bone. And so within here, within the spinal canal is the actual spinal cord. And within the spinal cord is, remember, it's still wrapped into, for the most layers, up until the lumbar layer, a good chunk of the spinal cord is still wrapped in dura, right, and meninges, okay? And so remember, meningitis and meninges aren't just the brain, they go all the way down to the spinal cord for most of the way down, okay? And so, let me just draw this. The spinal cord, it does look like that. There's white and gray matter. And there's nerves that branch off, and these nerves will branch out through these processes right here, the lamina. And so it'll come through here and kind of branch off and out, okay? Okay, well. And so in between each disc, we have this spongy stuff called fibrocartilage. And it's fibrous and thick and fairly hard, but relatively spongy and squishy. And so this helps protect our spine from trauma and standing and weight and all those issues. And so this is an issue you see occasionally, well, actually very commonly, with you've probably heard, oh, I have a herniated disc. Well, what they're saying when they have a herniated disc is the fibrocartilage has herniated, just like a hernia into the scrotum or into the abdominal wall or wherever. It's herniated outside of its original compartment, and so it's been pushed through, usually in this direction, towards the posterior. And so when this, well, it doesn't really matter. It can go either way. But what happens when this happens, things get displaced and they can get pinched, or this cartilage can push on the nerves and cause nerve pain as well. So there's several issues. The nerves can get pinched, one, or the nerves can get pushed on, or the spinal cord and the vertebra get out of alignment. And so all of these cause issues like pain. And even in severe cases, neurological dysfunction, to where you don't have proper nerve sensation or movement, where you have radiculopathy, or just all these issues that can show up from a herniated disc. But this is very common, and where this happens most commonly statistically is in the L4, L5, S1 region, right? So it's going to be pretty low in your back. If you've ever had back pain, you know right where I'm talking about, because this is where there's a fairly great curvature of the back, and so it's very susceptible to just kind of pinching out, like what you can see here. See how it's herniated out? It kind of like pinches it out of where it's supposed to be. And so, of course, with any type of extreme movement or flexion or extension or side-to-side movement even, or twisting of the back, you can have ligament damage. And that does happen, but what's very, very common is herniated disc. Very annoying. And I want to clarify, herniated disc can happen anywhere in the spinal cord. And so the CNS is, again, comprised of the brain and spinal cord. And the brain is the center of consciousness. There's major regions which we've covered before in the neuro chapter, but this is a good review. The cerebrum is the gray matter. It's the front part of the brain, the big chunk of the brain that you think about. The diencephalon, a very annoying word that refers to the hypothalamus-thalamus structures. That's this. So they're pointing here. The brain stem, remember, these are important structures of life, okay? So we have the midbrain, pons, and medulla oblongata, the medulla. And then the cerebellum. Remember, the cerebellum sits back here, and it is the GPS of the brain, of the body, that tells you, oh, my finger is here in proportion to my nose, and it helps with knowing where your body is in relation to itself. And so we could zoom in on this, but remember, skull, dura mater, there's going to be fluid here, arachnoid pia, right? That's the layer meninges, or a DAP, or a pad if you're going the other way. Then we have the cerebrum. This is the gray matter, okay? And then you have the hypothalamus-thalamus structure, also known as the diencephalon, after its baby name. That when it's a baby, we call it the diencephalon. And then, let's see, the corpus callosum means the great division. So your brain has two hemispheres, and the divider of that is called the corpus callosum, okay? And the brainstem, remember, you have the midbrain, which is about midway up in the brain, pons and medulla. The brainstem is absolutely essential to functions of life. And the cerebellum is back here, okay? Remember, when we get drunk, our cerebellum is what gets messed up. That's why we start walking weird and having difficulty with coordination. And so as a reminder of what the cerebrum does in itself, is we'll start with the easy one, the limbic system. So when I say limbic system, you should think happiness, emotions, right? That's the limbic system. Okay, it has to do with emotion and happiness too. So that's a system of itself. And then within here we have the frontal lobe. And so the frontal lobe is like your executive function, like conscious thought, to some degree emotion, smell is over here, speech is kind of in the temporal areas, and your primary motor area is up here as well. I'm not going to test you on these. Just know with the different lobes. Taste and hearing are in the temporal lobe, right? So that's over here where the temporal bone is. The parietal lobe is this main section up here. So this is where we have sensory and body awareness. Language also plays a role between speech and language. There's a connection between these two. Reading as well. And vision is the back. And it's really odd to me that your eyes, right, are all the way up here, and they have to travel all the way to the back for vision to be processed. And so vision is in the back in the occipital lobe. Occipital lobe, or the occipit, is the bony prominence. Just remember, cerebellum will coordinate the body movements. Remember, it's the GPS of the brain. The cerebrum is the big gray matter. And so the brainstem controls virtually all life functions. So if someone gets banged up in their brainstem, they're going to die very quickly because you have to have that to live. Absolutely have to have it. And so it's intuitive, right? The spinal cord is sending messages and impulses between the brain and the spinal cord and the rest of the body. So they're going back and forth. Remember, that is a two-way highway. Message is going down, message is coming up. And so we've talked about meningitis, but let's review the meninges. So we're working our way down we're penetrating. So you have the skin, then there's this fascial layer, muscle, skull, right? Bone of the skull. And then we have the DAP, D-A-P, right? And so it goes dura mater, which is like a leather-like consistency, arachnoid with bridging veins, that's what they're showing here. And then the pia mater is the deepest layer. And so if you were to go backwards, you would say, oh, well, these form a pad for the brain, right? Going this way, it's pia, arachnoid, dura, that spells pad. So they form a pad for the brain. Very important to know those layers. And I'll show you why when we talk about the upcoming stuff. When we talk about like a subdural bleed, it makes sense. Okay? So the peripheral nervous system, you have 31 pairs of spinal nerves and 12 pairs of cranial nerves. And so the cranial nerves don't go into the spinal cord. And so they exit somewhere other than the spinal cord. And so that they come directly off the brain, basically. And so that's why we call them cranial nerves. Okay? And you don't need to know exactly what they are, but those are all cranial nerves. And then, you might want to screenshot this. This is occasionally asked. And so these different layers, different sections, let me tell you why these become important. If someone takes a baseball bat to the neck, right, and we know, oh, well, they're still breathing on their own, but they can't move their upper extremities, then we suspect, oh, C5T1 at the brachial plexus has been damaged. Okay, but they're still breathing, so we know the lesion's at C5 or below. And so that's why these become kind of relevant or testable or important for you to know. And so C1 through 5, this is up in the neck, innervate the diaphragm. And what is the diaphragm? It's the muscle for breathing. So there's like a saying like C3, 4, 5 keeps the diaphragm alive. Very important to know that if you damage any of the C1 through 5, you have a good chance of de-innervating the diaphragm. And if you stop sending the diaphragm messages, you quit breathing, you die. And so this is the risk of cervical trauma, and one of the reasons we have to be really careful with cervical trauma. And then, again, like I said, the brachial plexus controls all of the upper extremities. And so if you were to break the brachial plexus at its trunk and like right off of the spinal cord, then your upper extremity would no longer work, and so muscle-wise and sensation actually. And so that would be a bad deal, but it certainly could happen. And so I'll give you an example. This would be like a quadriplegic, someone who broke it right here. They're not going to be able to use their arms or their legs because that means everything down here is not going to work. That's an example of a quadriplegic. And then L1 through L4, these are like skin and muscle of the abdominal wall and the genitalia too, and a little bit of the knees. But kinda, it's really L4, L5, yeah, S1 is 2. Yeah, L4 is the knees. And so, but L4, S4, so they're talking about lumbar 4, sacral 4, this range. Supplies the buttocks, perineum. The perineum is the area between the genitalia, like the penis or vagina, and the anus, and most of the lower limbs. So like the further you go down, like S1, S2 is going to be the ankle reflex, and so L4, L5 is it's just L4. Yeah, L4, L5 is going to be the knee reflex. Okay. So those are annoying, but they're kind of worth knowing, or at least having a general idea. If you get lost, just think the further you go down, like these are branching off, right? And so it wouldn't make sense for something down here at S4 to be innervating the arms. It doesn't go that way. They're all shooting downwards like this, okay? So just think like, oh, wow, someone's arms aren't working, don't pick S5. That can't possibly be it. It's going to be one of these up here. Somatic nervous control. Somatic control is things you can voluntarily control. And so cranial nerve, so that's worth knowing. But the cranial nerves pass through openings in the skull. There's several different areas they pass through. And like I said, these don't go through the spinal cord. They're shooting directly off of the brain, at the level of the brain stem, actually. But it's not in the spinal cord yet. And so that's why we call them cranial nerves. And so that's worth knowing, cranial nerves. There's 12 of them. And so peripheral nerves conduct sensory impulses from the skin and other impulses up to the spinal cord and back up. So remember, you're constantly taking information from your environment through your senses, smell, temperature, vibration, proprioception, and you're sending that up the peripheral spinal cords into the central nervous system through the spinal cord, or I should say the peripheral nerves, into the spinal cord and up into the brain to process what it is that you're doing and like regulating with your environment. So it's kind of, I keep saying it's worth knowing, but these are all things that you need to know. Okay, and so this is a reflex, and so your reflex, your body can do things without you thinking. And in fact, I think the body does a lot more things than what we realize without thinking consciously. And so they're showing you here, patient touches hot flame. Signals are sent up to the spinal cord and not necessarily up to the brain, and immediately you'll jerk back, right? And so that's a reflex. And so that is an example of a reflex. And so, you can see this in someone who is falling, someone who has grabbed something hot, someone who is startled, right? You see reflexes in different ways. And as we get older, our reflexes slow. And so this is why old people will trip, and instead of tripping and catching themselves like I would, they will trip and fall because they cannot catch themselves because their reflexes and coordination are not fast enough anymore. So the autonomic nervous system sounds like what it is. It is the automatic nervous system. And so we divide this into two branches, and we've talked about it. And so you might know that the sympathetic nervous system is controlled by the hypothalamus. I don't find that important. But the sympathetic nervous system is your fight or flight. So if you're about to fight a bear, right, your heart rate's going to go up, your bronchioles are going to open, your eyes are going to dilate to let all the light in. You're going to get ready to fight. Versus parasympathetic is rest and digest. And so, if you're about to eat a big Golden Corral buffet, right, you might get real sleepy and your belly's going to get all the blood and your mouth might be watering, right? And so that's your eyes are going to get heavy. That's rest and digest. And so that's the two systems. And remember, these two systems are always at play. One of them never turns completely off. So they're constantly just in balance. It's just at a given time, if you're about to fight a bear, the sympathetic system is going to pick up a little higher. If you just ate at Golden Corral, the parasympathetic nervous system is going to pick up a little bit higher and override. But they're always working together. So head injuries, you can have an open or a closed head injury. They are what they sound like. A closed head injury means that you don't have to fracture the skull, but the skull, it's not open, okay? And so you could have diffuse axonal brain injuries, diffuse brain injuries, focal brain injuries, or a skull fracture. It's just, to make it simpler, if you just know what an open head injury is, it makes it easier. An open head injury means the head is open. It's friggin' open, right? And so you have busted the head open. And so the dura mater and cranial contents can be penetrated and exposed. It is fairly common if you have an open skull fracture for brain matter to escape because of the pressures within there. And so that's a common thing that you'll see. Okay. As you can imagine, if someone has an open head injury, it is almost always going to have some type of neurological defect. It's pretty rare for someone to have an open head injury and not have an issue. That's what I'm talking about. This is scary. There's blood on this guy's face. And it's an itty bitty lack, right? It's pretty small. And it probably just happened. But, you can see it disfigures him, and it is scary. And so, these can bleed profusely. But how do we stop all bleeding in the absence of a tourniquet? You can't put a tourniquet on the head with direct pressure. So apply direct pressure to that, and it will likely stop. Now, we've talked about this. This is what they call battle signs. It's rare, to find this in the pre-hospital environment, because if I were to punch you now, you're not going to be bruised like that immediately. It's very rare. And I've talked about this, but this is called battle signs. So when you break the basilar skull, you can get a particular set of signs and symptoms called battle signs. Remember, basilar skull is this bottom part, right? It's the base of the skull. And so you'll get what's called periorbital ecchymosis. Peri meaning around the orbits, periorbital. Ecchymosis, this is the color of a bruise. So this is called bilateral periorbital ecchymosis. Okay, you want to sound sophisticated, you call it that. But you can also get what's called post-auricular ecchymosis or bruising as well. So you call this like post-auricular hematoma, post-auricular ecchymosis, contusion, doesn't matter. And so this is bruising behind the ear, and this is also a very hallmark sign of a basilar skull fracture. You don't see this very often. This is a late finding, but it can happen. And so you would imagine if you roll up to a scene and your patient looks like this, you're like, oh gosh, something is definitely wrong. Okay, and so these are sick patients. Now, there's different types of skull fractures that are, again, these are intuitive. Think about what these words mean. The word linear means in a line. So this would be here. It's the line's traveling this way. It's in a line. See how that's in a line? That's a linear skull fracture, the most common type of skull fracture. Okay. The second one is a depressed skull fracture. There is a friggin' depression in this guy's skull. Okay. Not open, but it is depressed. So if you were to palpate gently, you would feel a dip into this guy's skull. Okay. So maybe you took like a rock or a baseball bat to the head. Basilar skull fracture is the base of the skull. And so this is where you'll commonly see the periorbital ecchymosis, post-auricular hematoma, and so that's where you see battle sign. And then this last one is an open skull fracture. So maybe they took a hatchet or a gunshot wound to the head or a very severe fall, or it's very severe trauma to cause that. Okay, this is most commonly life-ending, right? Like it's very bad when you reach this. Okay. So again, on your exam, don't throw up your hand like I don't know. Right? Well, what does linear sound like? It sounds like it's in a line. So find the one that describes a line. What does depressed sound like? Like a depression. Okay. What does basilar sound like? Like the base of a skull. And what does open sound like? Like it's opened up. So use these words. I just see students be like, I can't figure it out. And I'm like, no, like just sound out the words. We'll get through it. So there's different types of brain injuries, and so the primary brain injury is caused instantaneously from the impact of the head. And so we can't do anything about this. As paramedics, doctors, the fall has already occurred. Let's just use a fall. Grandma has already slipped and fallen in the shower and banged her head. That's the primary injury. She hit her head. Okay? Primary. It's the primary brain injury. Now, the secondary brain injury is what happens after the fall. And so this is where we come into play. We try to prevent this. Because what happens is the brain will start swelling or bleeding, and sometimes we can prevent that, or we can at least treat that or make it not worse. And so we play a role in secondary injury treatment. The primary injury has already taken place before the 911 call is even placed. And so we try to limit secondary brain injury. That's what we're aiming at. That is our treatment. Okay. And so MVCs are a leading cause of brain injury. Again, people bang their heads in a car, windshields, posts, flying objects, like in the car, like debris, like a what are those cups? A Stanley Cup, you know? Imagine taking one of those to the dome at 80 miles an hour. And so the pattern you'll see is a coup counter coup injury. And so I've talked about this. A coup is when it goes forward, bam, hits the front of the skull when he hit the windshield. This pattern's called a spider pattern in the windshield. And then the brain goes forward, and then boing, every action has an opposite and equal reaction. The brain goes back. And so now the brain goes boing, boing, and it hits the back of the head. And if there's enough energy, it'll go boing again, coup, counter, coup, right? And so it will go back and forth. And so that's where you can get these injury patterns, boing, boing, in there. Okay? And the injured brain will swell, and initially it'll cause cerebral vasodilation. Okay? And that's because there's an injury response to that. And so as you increase cerebral edema, remember edema is the medical word for swelling. So if you increase cerebral brain swelling, cerebral edema, it further contributes to the swelling because remember the cranium is a confined vault. And so as you have swelling in there, it creates more injury because it's being swelled on. So it's like, stop swelling, and then it swells more. And so you get these problems, and there's nowhere for all this pressure to go, and so you get more and more issues. And so eventually you can get so swollen that you'll get low oxygen levels. And when you get low oxygen levels, you have further injuries, so you get more edema. And so cerebral edema is like your arch nemesis with head trauma because it kills people and it creates all these problems for you. As a reminder, there's something called the halo test. You can take a piece of gauze and put it up on a patient's ear if they're leaking blood or fluid, and you'll see a halo stain. So this is blood with cerebrospinal fluid on the periphery. So that's called a halo test. Sometimes it's just straight up pink water dripping out of their ears or nose. That's bad. That means the dura mater, meaning the meninges, have been penetrated. That's bad. Cushing's triad, a very important concept. So this is triad means three, right? Like a trio or whatever, right? And so a triad is the Cushing's triad, which you absolutely need to know. Says that you're going to have an increased, we'll do it this way, blood pressure with a decreased heart rate and with irregular breathing. That is Cushing's triad, not Cushing's disease. That's different. That has to do with the kidneys. And so this is Cushing's triad. And so what you'll see, classical vignette, 25-year-old male, motor vehicle collision. You find him unresponsive at scene with irregular respirations, a blood pressure of 186 over 140, and a heart rate of 42. What is this called? Cushing's triad, right? And so watch for that. It's very rare. It's very weird to have that high of a blood pressure with that low of a heart rate with irregular breathing. Those three put together, we named it after this dude named Cushing, who was a very busy guy. There's a lot of things named after him, but this Cushing's triad is referring to head increased intracranial pressure. Okay, so you can see this in head trauma as there's swelling and increased pressure. There's increased blood pressure, decreased heart rate, irregular breathing. What are those irregular breathing patterns called? Biots, chain Stokes, acoustic respirations, any of those. They may use some of those words, especially chain Stokes respirations. Remember, chain Stokes is where you breathe a little faster, 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 apnea. Faster, 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 apnea. Remember, apnea means not breathing. And so that's chain Stokes respirations. It means there's an increased pressure on the brainstem. This is very lethal. And so what's the treatment for this at the EMT level? Well, they did use the word irregular breathing, irregular ventilations. So what do? We fix that. We ventilate them. That's really all you can do at the EMT level. Okay? And so this whole ICP or intracranial pressure, bleeding inside the skull increases ICP. You see this in hemorrhagic stroke. We've covered that in a previous chapter. Increased ICP squeezes against the brain and the cranium and eventually the brainstem. And this causes patterns of herniation to where, remember, when brains or nerves get pushed on, they don't work well. So you can herniate, where you'll herniate. The brain kind of moves. And as it moves and gets squished on and squeezed, it doesn't work. And it creates these predictable sets of signs and symptoms. And so what eventually happens is there's a response to decreased cerebral perfusion pressure by increasing the MAP. And so again, this is the reason you get this high blood pressure is the body trying to save itself, and it just gets worse because it causes problems with your breathing and your heart rate. And so you don't need to know at this point in paramedic school. You need to know why this happens, but just do know this. You need to know Cushing's triad. Increased blood pressure, high, like 180 over 150, something bonkers like that, with a low heart rate of like 50. And they'll say irregular breathing, chain Stokes breathing, Biots breathing, apneustic breathing, right? Something like that. They'll give you some type of irregular breathing. Now, the corticate, decelerate posturing. Remember, the corticate, you're up in the core. This is the core of your body. So that's flexion, right? So they're flexed in. And over here on the GCS score, that's this one. That's number 3 on the GCS score. And then the worst one is flexion. So this is decelerate posturing. And so decelerate posturing is down here. This is decelerate. And so you'll see this clinically. You'll see this like in patients that have head bleeds that are dying. They start up like this, and then as they like continue to die and herniate, their arms will go like straight and extend. Very sad. I mean, it's not like you can do about it, right? And so you'll see this maybe at some point in your career. But you ever wondered, like, why is there like flexion extension on the GCS score? That's it. It's these. Okay. So when they start extending, that's even worse. Well, yeah, there's a reason why that happens. It's not important. Now, we're going to talk about different brain bleeds, and I think I've covered these before. I really thought we did, but they're showing up again. So the fact that they're showing up again means we need to know them. And so this is called an epidural hematoma. So epidural, meaning it's above, epi means above, outer. So it's above the dura mater, which is the outermost layer of the meninges. And so basically what happens is you get bleeding between the skull itself and the meninges, this like leathery substance called the dura. And so you get bleeding here. And so what happens in this particular injury is people will usually get hit here in the temporal lobe. And if you don't know, there's the bone right here in your skull called the pterion is very thin. It's the thinnest portion of the skull. And so if you get smacked here, God was not very friendly with us on this because he put these arteries through here called the middle meningeal artery. And so you can snap this artery when the bone breaks. You can kind of shear this artery. And what do we know about arteries? These are the ones that shoot blood across the room, like arterial bleeding. And so you end up with this arterial bleeding that creates problems very fast because the pressure is going to build up really, really fast. And so the hallmark of an epidural hematoma is the patient will, like if you ever read this in a vignette, you need to think epidural hematoma. They'll get knocked out, right? Let's just say they baseball to the head, right here in the temporal region. They'll get knocked out immediately. They will regain consciousness, or they'll use the word, they have a lucid interval. They come back to, and as pressure builds up in here, they will go back unconscious, and they'll die if no intervention is performed. And so very, very lethal. I mean, this is bad. This does happen, though. It's pretty common. And so this is an epidural hematoma. A few things to know. Again, a period of unconsciousness, lucid interval, and unconsciousness is a common way it's described on exams. Doesn't necessarily happen that way in real life, but it is described that way on exams. And this hematoma will develop very quickly, and this is very, very fatal. And it creates this concave disc shape on a CT, but you don't need to know that. So that's an epidural hematoma. Now, cerebral contusion is intuitive. It's a bruise to the brain. And so remember that whole counter-coup thing? Those you would probably be bruised in the front and back of your brain. Now, this next one called a subdural hematoma. Sub means below, like a substitute teacher, right? Like they're below the teacher, they're subbing in, right? And so, or the sub athlete, or like they're subbing in, they're below. And so, subdural means below the dura. And remember, the dura is this leathery substance. And so, remember I told you a long time ago, we have these things called bridging veins. And that's what connects the dura to the arachnoid matter. And so as we age, our brain gets smaller and smaller and smaller. And when we're first born, our brains are really small. And so who gets subdural bleeds? It's old people and alcoholics, because if you drink a lot, your brain will also shrink. And so what happens is they usually will receive like some type of trauma, like a fairly minor fall. Like they fell and they bumped their head. And it was enough to tear one of these veins. And so as you tear these veins, they bleed, right? And what do we know about veins? They don't bleed very fast. And so it bleeds and bleeds and bleeds and bleeds. And so this is the one that can accumulate over a chronic period of time. And so these are the patients that are like, oh, well, I fell last week in the shower, but I felt fine. And now that looks like they're having a stroke, and they're all neurologically not intact. And so that's called a subdural hematoma. And so this is accumulation of blood beneath the dura mater, but outside of the brain itself. And so this happens, again, fairly often. And so this is the bleed where the classic one is like, oh, I fell 4 days ago and I thought I was fine, and now the patient's not fine. And so this is why we inquire about, have you fallen or been injured, any types of car wrecks, anything major or minor in the last 2 weeks. This is why you ask patients that, because this could be the presentation. Now, this last one, not as common, but it does happen, called a subarachnoid hemorrhage. So remember, we went dura, arachnoid, pia mater. And so arachnoid's kind of in the brain itself. And so this usually happens from what's called an arterial venous malformation, or basically where you'll get like a little rat's nest of arteries and veins. It's a malformation. It's not supposed to be there, and they explode. And so when they explode, you'll get this bleeding that happens up into the brain tissue itself. And so this is, these patients say, oh, it's the worst headache of my life, and they die, right? And so this is the worst headache of my life type people, where pop, it pops, oh, it's the worst headache of my life, and very quickly they're going to start quarter posturing and then dissever it. Okay. And so this can be very lethal, of course, as well. And so you'll see, I've seen this clinically in the field, to where like the guy told his son, oh, I heard a pop. Like literally told the son, I heard a pop. I have the worst headache of my life. We get there 10 minutes later, and he's already posturing. Get him intubated, and a few minutes later, after being intubated, he dies. So it's very bad. Now, a diffuse axonal injury or diffuse. Okay, so let me just talk about a concussion. Okay. A concussion is caused by a blow to the head or the face if the brain is jarred around the skull. So basically, the brain got jarred, got kind of shook up. The brain doesn't like that, okay? And so it's technically considered a mild traumatic brain injury. And so, again, we know the brain doesn't regenerate, so this is why we're being more mindful of concussions in contact sports and stuff like that, okay? Whole nother chapter or discussion. But we also have these things called diffuse axonal injuries. So remember, nerves carry their messages down an axon, and these can get sheared, right? So you have all these dendrites, and it travels down a single, wrong color, that's not a good example. You have all these dendrites that connect to the single axon. It travels it down, and then it kind of shoots off to its target tissue, right? And so what happens in a diffuse axonal injury is usually it's associated with a rapid acceleration, deceleration thing, like getting punched or kicked in the head, or a severe car wreck, or even any type of trauma where you have rapid acceleration, deceleration. Like again, being punched, the head rapidly accelerates and then or deaccelerates. And so what happens is you can get these can get sheared, they get like stretched. And so when they get stretched, you may not see anything on CT, and you probably won't, but this is an MRI, 2 MRIs of a different patient, to where you see these, like, you don't have to be a radiologist to be like, why are there holes in this guy's head? That's not normal, okay? And so these are diffuse axonal injuries, and there's some here as well. You can see these like little white spots. And so that's kind of a diffuse axonal injury. Just know this is, so you've ever heard of those boxers that like get punched and they're in a wheelchair for the rest of their life? That's this, right? That's them, diffuse axonal injury. And so, of course, these can be mild in nature, but the more severe ones, you don't recover from these. That's why they have a poor prognosis. What's a prognosis? That means your outcome. These patients have poor outcomes. And so, spine injuries. So the spine itself, we particularly worry about the cervical spine, but the whole spine can be injured, okay? And so we have to worry, remember those fibrocartilage discs called the disc of the spine? Those, when we compress them from a fall, so someone falls off a ladder, they fall 5 feet and they land on their heels, blink. When they land, all that energy is transferred up through their spine from their heels into their spine, and so it compresses the spine, so you can get a compression injury from the fall. The same thing could happen like the other way, diving into a pool head first, and you hit your head first, you can compress those discs, cause herniation and breakage and all these issues. So you can get compression injury, motor vehicle crashes, falls, diving injuries. When I say diving, I mean like diving head first, jumping injuries, all those types of things. Now, speaking of the neck, when we speak of the neck and the spine, I think if I say, hey, cool guy, flex your bicep, you're going to go like this. But if I said, hey, cool guy, flex your neck, how are you going to do that, right? And so flexion of the neck is bringing your chin down to your chest. So that's like, this is a flexion. Extension is bringing your head back, okay? My neck's really stiff. That hurt. And so Flexion injuries result from forward movement of the head, right? And so typically from rapid deceleration or direct blow of the occiput. So you can imagine this. If you're going 80 miles an hour and hit a brick wall, your head's going to go like this. That's a flexion injury. If you're sitting there and someone punches you in the back of the head, your head's going to go like this. That's a flexion injury. Now, rotation with flexion, this is like a motor vehicle collision, a lateral crash where you get T-boned. And so this is where you might get like hit, and so you would flex with rotation. Obviously, that's going to be pretty bad too. Now, again, vertical compression, you can not only just herniate these discs, that's likely if you compress them, right? But you can fracture the disc. And where this normally happens is in the curvature of the spine. So this is your head. And so this is the thoracic spine, this is the lumbar spine, sacral spine, coccyx, cervical. And so what happens is like right here in this curve, this is a favorite place to get compression injuries, okay? Of course, you can get these in the neck as well. You can get them anywhere. But the lumbar spine is a favorite for spinal injury. And so just imagine this: you're jumping from a tree and you land on your heels. That energy is going up your legs, through your femur, into your spine, and so your spine will go pop, 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 and if it can't absorb that energy, it'll snap, it'll break. And so this can be caused obviously by a jump, a direct blow, rapid deceleration from a fall, and can cause herniation of disc. Remember, these are the disc, and they can herniate this way or this way even. Okay. So they get squished. And so when you see this on x-ray, you'll notice that this is not sitting like kind of nice and flat, but it's sitting like this. It's pinching whatever's coming over here. And so, this is exaggerated, but you can imagine what that would feel like. You're pinching nerves, so it hurts. Hanging, very gruesome call. You will never forget your hangings, right? They're very scary. But they do happen. And so hangings kill people in two ways. First, and the most obvious, is suffocation, and this is probably the more common way because nooses aren't tied properly, right? They'll just loop like a belt or something, and it doesn't break their neck. But so strangulation, asphyxiation is the most common way is a common way that people die from hanging. But it's a double whammy, right? So if they also like jump off of something or fall off a tree or something, you can distract the neck and you can break the neck as well. And so you tend to break the cervical neck, and what keeps the diaphragm alive? C1, 2, 3, 4, and 5. And so if you break it enough, you can shear the spinal cord through a distraction, and it's called a distraction injury. When you hyperextend that spinal cord, you like shear it, and so this you just break remember the atlas and the axis, which are the first two, C1, C2. You break those as a unit, and you just break the spinal cord. So it's bad, But I read a lot of hangings where I'll just tell you, the new thing is like I've seen people, they'll tie a belt around their neck. It's very odd to me, very sad, and they'll just lean forward and they just strangulate themselves. It's not necessarily a hanging per se; it's more of an asphyxiation, strangulation thing. But I've also ran them where they've jumped out of trees and they're hanging from trees, or stuff like that. So very, very sad, very, very sad, very tragic. And so spinal cord injuries, this is what I was talking about earlier. So if you break like C5, 6 or lower, your diaphragm will stay alive, but you're going to be a quadriplegic. Quadriplegic means quad means four, like a quad four-wheeler, It means four. So you have paralysis in all four extremities. Versus a paraplegic is like usually from like the belly button down. And if you break like L1 or below, you'll be a paraplegic. And you might say, what's hemiplegic? That means that it's half the body, so like just the left side or the right side. That's the difference. And so the primary spinal cord injury occurs at the moment of impact. So again, that happened before 911 was called. It's either a concussion, a contusion, or it's severed. We can't fix that, right? That's already occurred. But our job as paramedics and EMTs, and we're trying to prevent secondary spinal cord injury. We're trying to not make it worse. So we're going to stabilize it. We're going to not move them around or allow further shearing or tearing of the nerves or the spinal cord. And so we do this through results from primary spinal cord injury progress to further deterioration through swelling, and further manipulation and movement can further injure this. And so we minimize heat loss, maintain oxygenation, maintain the airway, and perfusion is key. And you'd say, well, why is, I think it's coming up. Why is perfusion key? Well, there's spinal shock. And so, or neurogenic shock is the better one there. Let's talk about neurogenic, we'll come back. Neurogenic shock is from loss of sympathetic tone. So you lose loss of sympathetic tone. And so when you lose the sympathetic nervous system that's telling vessels, hey, buddy, clamp down, you're about to fight a bear, the parasympathetic system will take over. And when it takes over, you get like widespread vasodilation. And so you'll get hypotension, and you could get bradycardia too, because it depends on the level, because you've lost the sympathetic nervous system at that level and below of the fracture, of the transection of the spinal cord. And so, a hallmark of this is you'll get hypotension and bradycardia. And so watch for that. When you hear someone who sustained a fall or a trauma, and they're hypotensive, and normally with hypotension, we see tachycardia to compensate, right? But when you see hypotension and bradycardia, meaning low blood pressure and low heart rate, that's odd. Our body's not reacting the way it's supposed to react because it can't. It's been hurt. It's been damaged at this particular level. And so this is where you'll see hypotension and bradycardia. That's neurogenic shock. It's a form of distributive shock, by the way. And so, because the stuff goes in the wrong areas, distributed in the wrong areas. And so spinal shock will occur immediately after the spinal trauma. And so sensory function below the level will be impaired. It really depends on the exact injury, but you could imagine if you completely break your spinal cord, you're not going to be able to feel below that level. Generally, yeah, let's just go with that. What is that called? What is that pattern called? It's called a spider pattern, remember? And so consider the need for paramedic backup. Refer to high-risk mechanisms and determine the possibility of spinal injury. So if you roll up to a wreck scene and you see this, does this patient need a C-collar and backboard? Or do they need cervical spinal cautions? Yes, they do. Yes, they do. And so we've covered this in class. We'll cover it again the week that you're watching this video, and we'll talk about how to take off helmets. And so spinal immobilization of the cervical spine in a neutral inline position, right? So we hold it in its manual inline position. We don't release that until it has been placed and secured, right? And so focus on identifying and managing life-threatening concerns. Life-threatening external hemorrhage must be treated before airway and breathing concerns. Remember, it goes X for exsanguination, airway, breathing, circulation, disability, and I think environment. I don't know. I don't know all these new ones. Evaluate and monitor the level of consciousness. Ask responsive patients about the mechanism of injury and their symptoms. How are you feeling? How did this happen? What do you remember? Did you lose consciousness? Can you tell me exactly what happened? Do you remember all the events before this? What were you doing earlier today? Who called 911? Right? Events like that to where you can determine their neurological function. Unresponsive patients with any trauma should be assumed to have a spinal injury. This will burn students alive on exams. They'll be like, 82-year-old lady, diabetic, found unresponsive on the rug in her living room with cool, clammy skin. What should your first action be? And they're gonna be like, oh, give glucose. The answer is inline spinal mobilization, right? Cervical spinal precautions, because she's unresponsive on the floor. So watch out for that. When they tell you like someone's on the floor, you need to think that they fell. Okay, so you have to assume that they have spinal injury until proven otherwise. That's the rules. I don't make them. Airway management. So you might have to suction these patients' mouths. When we roll the patient, this needs to be a coordinated effort to where, remember, the patient at the head is in charge of any movements. So we're going to say roll to the patient's right on 3, 1, 2, 3, because they're vomiting. Roll to the patient's right on 3, 1, 2, 3, roll. All right, we're rolling back to the, we're going to go back to the back on 3, 1, 2, 3, rolling back, right? And so you're making eye contact with each of the people on your team, assuming or making good command presence, telling everyone exactly what the move is in clear English, clear language. authoritatively and clearly. Those are the rules. So this will also burn students. 82-year-old lady found face down on the carpet in her living room. She has irregular breathing. What do? You're going to be like, oh, I do a head tilt chin lift. Wrong. She's unresponsive on the floor. You have to assume she has trauma to her cervical spine. It is a jaw thrust. It is a jaw thrust. We don't do head tilt chin lift and manipulate someone's broken neck. It is a jaw thrust. That is the answer. Okay? So be very mindful of that. It gets you all the time. They'll suck you into the perfect medical emergency. 22-year-old lady covered in hives, bees all surrounded her, and she has irregular respirations. How do you open her airway? Jaw thrust, because she is unresponsive on the ground. Jaw thrust. You have to assume she has trauma. And so sometimes we have to ventilate these patients. Remember, if you whack the C1 through 5, if those get injured, they're not going to breathe, and so you'll have to ventilate for them and provide adequate oxygenation and ventilation. You might still initiate CPR. You assess for radial pulses. Generally, if someone has a radial pulse, their blood pressure is like 80, 90s or higher, give or take. Systolic, the top number. Assess for signs and symptoms of shock and treat the patient appropriately. Decide early whether to complete the secondary assessment on scene or transport immediately. Generally, take them to the hospital. Just transport them. You can do a secondary assessment in the back of an ambulance. I've done it. You can do it. Prompt transport definitive care facility is crucial. So just take them to the hospital if you can. Like don't play around on scene if you don't have to. As a general rule, the only time you stay on scene is if you have to, and you usually don't have to. Maintain a patent airway and provide high flow oxygen. In supine patients, you could consider elevating the head of the bed 30 degrees. And so I don't have my protractor, but if this is the stretcher, 30 degrees is like this. If that's the head of the bed. So the patient would be sitting like this. Like that. Something like that. Take a good history. Same thing in all these. We use family members, friends, neighbors, jewelry, cards, context clues, open pill bottles. We use our context clues, the environment. Remember the mnemonic OPQRST, onset, provocation, quality, radiation, severity, time. We use this in trauma, especially when patients are complaining of pain. That's how we document pain. Obtain vital signs. Modify the physical exam for any patient suspected spinal cord injury, apply manual stabilization while asking the patient not to move. Interestingly enough, when you tell someone not to move, they're going to be like, what? And they're going to move. But try to have the patient not move. Monitor the patient for changes in level of consciousness. Estimate the severity of increase in ICP. Yeah, you could watch for signs of herniation. What are the signs of herniation? Altered mental status, decreased level of consciousness, decorticate, followed by decelerate posturing, a lowering GCS score, a lowering heart rate, an increased blood pressure, irregular respirations like Cheyne-Stokes. Those are all signs of increased intracranial pressure. Not good. Patients on their way to heaven. Not good. So they need to be transported so they can get trauma surgery, neurosurgery sometimes. And so we obtain our baseline GCS scoring, and so we can use this clinically, right, as a baseline. Like, oh, well, when we got there, they were GCS of 14, and holy smokes, we're at the ER, they're GCS of 8. We move them over to the ER bed, they're GCS of 3. They're dead, right? And so we use this clinically to reassess, so do be using that. And then we can expose the patient to examine the spine. Remember when you roll the patient to place them on a backboard, if that's what you're going to do, you coordinate to where someone's going to feel and palpate and examine and palpate the spine for deformity. Crepitus step-off deformity. What is a step-off? That's when, like, if these are your vertebrae, that's when one of them steps off. And so you're feeling down, like feel. Ooh, that steps off. Feel. And so that's a step-off deformity. You can feel that when it's very broke, the spine. And so you would test grip strength. Okay, I need you to squeeze both my fingers tight, 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 squeeze tighter. And you would want to make sure it's equal grip strength on both sides. Okay, I'm going to ask you to push down like you're pushing on the brake pedals. Push, 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 right? And so they should be able to push down. And I'll take my hands on the other side and I'll push your toes up towards your face. Push, 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 push. And then so, you can assess motor sensation that way. You can also have the patient close their eyes and test sensation. All right, close your eyes. Yeah, I'm going to close their eyes and say, I'm going to touch. Tell me what side I'm touching. Touch both sides. And if they're like, oh, you're just touching the right side, then they don't have sensation on the left. So that's how we do that. Okay. So spinal cord injury also may produce pain independent of movement or palpation. What does that mean? Pain independent of movement or palpation. That means they hurt like crazy just sitting there. It just hurts. So be aware of that. Evaluate the chest and abdomen. Remember, if it's enough energy to break the spine, you have to worry about internal injury to the kidneys, the pancreas, the abdomen, all the muscles, all those issues. Auscultation to assess breath sounds may reveal a shortened inspiratory phase. That could indicate like a diaphragm issue. Remember, the diaphragm is the main muscle of inspiration, but you also have the intercostal muscles that help. Continuously monitor for signs of shock. Look for abnormal posturing. Decorticate is a number 3 on the GCS score on the motor section. And decelerate is even worse. That's when they extend. And so that's a number 2. Very bad. Oh, assess for blood glucose level. Remember that anytime you have altered mental status, you need to check out blood glucose. So even if someone, was in a car wreck and they have an altered mental status, but you're like, oh, maybe it's just the spinal cord. Just check a blood glucose. So we check blood glucose on anyone with an altered mental status. Really, any critically ill patient, you should be checking that as well. But any patient with an altered mental status, it's negligent to not check a blood glucose level. Frequently monitor and assess vital signs. Spinal cord injuries responsible for neurological shock also usually produce a flaccid paralysis and a complete loss of sensation. And so this is true. Flaccid paralysis means it's just floppy. And so you would have complete paralysis of whatever extremity, the legs or the upper extremities if you break the spinal cord. It's a lower motor neuron lesion. And so one thing I'll have you know, you don't see this very often. This isn't me being weird. You can get what's called a priapism. It's the medical word for an erection of the penis in men. And so what happens is so if you don't know, the parasympathetic nervous system is responsible for erection. And so again, if in neurogenic shock, when you take away the sympathetic nervous system, the parasympathetic system takes over, and one of the functions of the parasympathetic nervous system is erection. And so you can get an erect penis from spinal trauma. And so this isn't a routine exam you would do, and you wouldn't expect to walk up and find someone, quote, pitching a tent, right, with a very erect penis sticking straight up. But it can happen. And I've actually have 2 friends that have been in, one was a police officer and one was a paramedic who have told me that, yes, I have seen this before, actually. I have not. Now, when I teach this, I want you to know that it's typically not a true, very firm erection, but it is usually a partial erection is what the literature says is more common, but exams don't say that. They'll say priapism is noted. Remember, priapism is the other word for erection in medicine. And so just watch out. If you see, oh, guy was on a motorcycle, got ejected, and he has a priapism, boom, neurogenic shock. They're telling you that. They're spoon feeding you that if they tell you that. If they say priapism or an erect penis after trauma, neurogenic shock, spinal cord injury. That's what they're telling you. So, you treat head injuries with these general principles, right? Maintain the airway, maintain perfusion. IVs are for advanced in paramedics. I'm going to take that out. And continuously monitor. The patient can be meh when you get there, and 10 minutes later be dead. These are very dynamic patients because, again, the brain don't play. And so it can very quickly cause very significant changes in presentation. And so Yeah, don't allow the patient to become overheated. I meant to take out that slide about IV stuff. Of course, we're not starting IVs at the EMT level. Okay, so you won't be tested on that. Now, scalp blacks, we've talked about this in the previous chapter and we show you this in class, but you can actually get hypovolemic. You can bleed so much. I ran a lady once in Brock. She was on Plavix, which is not a blood thinner. It's like aspirin, just much more powerful. So it causes prolonged bleeding, sure. But she hit the back of her head. She fell outside, like raking leaves, and she fell on the sidewalk and cracked her head open. So she had a big lax to the back of her head. And this lady bled so much, she was almost in shock. I could not stop her bleeding. As tight as we were pushing and as much pressure as we were applying, by the time we got to Fort Worth. And so be aware, these do bleed a lot, especially big lax, okay? So this is one of the few times you could use a dry sterile dressing and fold. And the reason you use dry is because the hair is covering it. But and fold any avulsion back down onto the skin. So again, you don't want to apply excessive pressure to the open wound because the reason is we're not entirely sure there's not a fracture underneath there. And so if you're like pushing like crazy hard, you could make that fracture worse. You could push into the brain. You could push into the meninges. There's a lot of issues you can get. So spinal injuries of the cervical spine. Stabilize the head and neck so potential fractured bone fragments do not cause further damage. And so if I were to show you an MRI or CT of someone's broken neck, you would appreciate that, like, if this is the spinal cord and like we're taking slices and this is what it like you have an impingement of this broken vertebra into the spinal cord. You don't want to be moving this more. You're going to push this further into the spinal cord and cause further damage. So the whole idea is to keep them stable to where you don't have more of this like movement to further exacerbate damage to the nerve or the spinal cord, which is just a series of big nerves. And so do not move the head any further in cases of muscle spasms in the neck, increased pain with movement, numbness, tingling, or weakness in the arms or legs. These are telling you the peripheral nerves are getting messed up, compromised airway or ventilations. And so just be aware of that. You don't want to make the patient worse. And so there would be a very, very, very small percentage of times where if you find the patient in this location and any movement is causing any of these symptoms, you would leave them in that position and just secure them in that position. Typically, patients will find comfort of an inline neutral position. But if they're reporting any of these symptoms, you would not want to move the head any further. We're going to talk about cervical collars a lot in class. I know I've already covered these. We're going to go over them again and start incorporating them into scenarios. But remember, provide preliminary partial support of the cervical spine to hopefully reduce movement. Assess PMS, pulse motor sensation in all the extremities. Okay? All the extremities. Before and after intervention, and with any movement, assess it again. Maintain manual support until the patient has been fully secured to the backboard. So this is manual stabilization, yeah. And then until they get there fully taped down and stabilized, they still have manual stabilization, yeah. It's a long backboard. It's a short backboard. We use this one more commonly in like extrication, okay? And it's like a vest. The other name for it is called a KED or Kendrick's extrication device. Texas law requires every ambulance and helicopter carries this. Don't ask me why. I didn't write the law. But even helicopters have to carry that. They're considered an ambulance. Now, I won't spend much time on this because I know y'all have covered this in class. And so I'm just going to cherry pick what I want to tell you. Slide the patient onto a backboard, or you can use a scoop stretcher. What's my other word for the scoop stretcher? What do I call it? The broken hip stretcher. Okay, it's a great thing. And so you'll take the stretcher apart and you'll scoop them up into it. Works really well. Seated patients, we use the KED. I'm a fan of this, but it takes a little bit of time, so you don't do this very rapidly. Now, helmets. We're going to cover this in class. I don't think y'all have covered this yet. And so questions to ask when a patient's wearing a helmet is the patient's airway clear? Is the patient breathing adequately? Can you maintain the airway and assist ventilations with the helmet on place? let me restart. If the answer is yes to all these, you leave the helmet on. If the answer is to no one of these, you may take it off. Can the face guard be easily removed to allow access to the airway without removing the helmet? How well does the helmet fit? Fits well, yes. Okay, leave it. If it fits bad, take it off. Can the patient's head move within the helmet? Can the spine be immobilized in a neutral position with the helmet on? And so, whether like for example, in a football helmet, you can take the face guard off with a screwdriver. So you might want to leave that one on. But like, I thought I had a picture in here where they have the like a motorcycle helmet that has the visor with the plastic piece that comes down. That's one solid piece. Can't take that off. So that would be a scenario where you're gonna have to take it off. And so a helmet that fits well prevents the patient's head from moving and should be left on. And so well-fitting helmets where you can remove the air, the front of it and control the airway, it can stay on. Specific conditions require the helmet to be removed. This is a fairly high-risk procedure. You don't want to do this unless you have to. But we're going to show you how to do this in school, in class. So again, if you can take this off by cutting it or with a screwdriver, that would be ideal. But if not, like if the patient's not breathing and you don't have time to find these tools, yeah, take it off. But typically you can detach the face part. Now, motorcycle helmets, those are the ones we're talking where they come down like this and they'll have a visor that flips up. Those are the ones that get annoying to where you're going to have to probably take off the helmet if you need to maintain or control their airway. Okay, and so it depends on the helmet that's worn, but basically what you're going to want to do is stabilize the head as well as possible. Try to stretch the helmet out to where when you take the helmet out, it's not dragging and pulling their neck with it. You're trying to like pull it apart while pulling it off. That'll make more sense in person, but you can imagine trying to release it from the skull, its grip on the skull and head, and then take it off instead of just yanking it off because it's going to take the skull with it. Okay? And so, you're going to take the jaw pads out of place, you put your fingers in the helmet, gently rock it back and forth, and like I said, you're pulling outwards to try to get this tension off of the skull, right? And so you just take it off. Like, I don't have much to say to that. Now, this is important, very important. We're going to talk about this in special populations. And so you may have noticed we've been pretty negligent not talking about kids yet. It's because they have their own chapter. This is the exception. We will show you this in class with our mannequins, our CPR baby mannequins. Babies have really, really big heads, bigger than mine. And so what you have to do, okay, if a baby lays flat, you can imagine that their neck's going to be like this because their occiput is so big, it kind of extends their neck a little bit. Their neck will look like this. That's extension. And so what you have to do is you have to pad up underneath their shoulders with like a towel or a blanket or something, usually a towel or blanket, to bring their shoulder height up to their big O head height. And so you can see they did that here, and that's kept this baby's spine in line. And you can imagine if this wasn't here, the spine is going to get hyperextended like this. And so you don't want that. Or even flex. It can go either way, I guess. It could also flex. And so this is why with babies and children in general, you have to pad under the shoulders. So you have to pad under the shoulders to prevent issues with this. So again, you can use rolled blankets or whatever to help with this. And so now if you don't have the right size, what they're saying here is you can pad all the way down to help secure them. See how they did that? They took blankets and just rolled them up, and they make it like a little cocoon for this guy to tuck him in. And so you don't do this very often, but this is the proper way to do it. Again, we will show you how to do this in class. Now, we've been talking a lot about trauma. Whoops, my thing moved. But let's talk about back pain, just non-traumatic spinal injuries. And so back pain is one of the most common physical ailments like ever, right? Everyone has back pain. I swear, you turn like 16, like your back starts hurting. It's downhill from there. And so the upright posture places a substantial amount of weight on the lumbar spine. Remember, the lumbar spine, I drew this for you earlier. Like here's the head, cervical, thoracic, and then so this right here gets a lot of like tension pushed on it by the physics of this. And so that's how you can get this pain on the lumbar spine, namely like L4, L5, S1 area. It's very common to get herniation there. And so spinal tumors can cause pain and debilitation. That would be rare. This is a form of cancer, but that can happen. Most causes of lower back pain are idiopathic, meaning we don't know why this pathology happened. Usually it's just from TMB, too many birthdays. We've been around too long. But I will say leading cause of this is obesity. Okay, more weight, more pressure on the spine, more injury. And so that's things to consider. Older patients with a history of osteoporosis are at higher risk for spontaneous compression fractures. And so what osteoporosis is, this is a disease of old people, specifically old ladies. Okay? And so it's because of estrogen makes this worse over your life. And so what osteoporosis is brittle bone disease. And so what happens is your bones get brittle as you age, especially little old ladies. And so what happens is they're more likely to get those compression fractures, those fractures like this in their spinal cord. And so they get they get spinal cord injury, and vertebral injury, really, namely, and then they'll get some peripheral nerve issue from this. And so, but keep in mind, osteoporosis is most commonly found, like we see issues in the vertebra, meaning the bones of the back, but it can happen in any bone. So an old lady's more likely to break her hip than an old man, statistically, because of osteoporosis. Not my opinion. Now, tumors of the spine can cause a pathological fracture. Remember the whole pathological fracture? These are the people that like roll over bed, not even like any substantial force, and they snap a bone. That's a pathological fracture. The pathology is from the cancer, the tumor. Degenerative disc disease, again, as we age, the disc will get smaller and thinner and thinner. It's quite common. It's a consequence of aging, unfortunately. Being overweight is a risk factor of that as well. Obesity. Disc herniation may be caused by some degree of trauma. Again, obesity is everyday trauma pushing on that. And prehospital management of lower back pain in the absence of trauma is really just palliative. Palliative is just aiding of pain, right? Trying to aid in discomfort. And so you take them to the hospital, and so a lot of times they may see a spine doctor, but it's just medication, pain medicine. Sometimes we'll give them muscle relaxers, but it's just palliative to try to treat the symptoms. Okay, that's it for this. That was a long chapter. My voice hurts. I'm tired of talking, but I appreciate y'all's attention. So with that.